Wonderful. Glad to have
Thank
you,
you.
Debbie.
Thank you.
Hi, everyone. I'm going to go ahead and call this meeting to order. Our SURG Prevention Subcommittee meeting for the month of October. Welcome everyone who's joined. We'll start with agenda item number 1, which is a call to order and a roll call to establish quorum. I'm going to turn it over to Emma Rodriguez to lead us through the roll call. Ms. Rodriguez?
Senator Fabian Doniate, Jessica Johnson,
Present.
Debbie Nadler,
Present.
Angela Nichols,
She might be muted. I did see her come on.
just asked her to unmute. Angela Nichols, can you just confirm you're present?
Did you see her text? She says she's here. She just has a training.
Oh, okay, great. Eric Schoen.
I'm here. Good morning, everybody.
Morning. And Senator Heidi Sievers Gansert. Right, well, we do have 4 out of 6 members currently present, so Chair Johnson, we do have a quorum.
Wonderful. Thank you so much, Ms. Rodriguez, for establishing quorum. We're going to move to agenda item number 2, which is public comment. Public comment will be received via the Zoom meeting, and public comment should be limited to 3 minutes per person. This is a period devoted to comments by the general public, if any, and discussion of those comments. No action may be taken upon a matter raised during the period devoted to public comments by the general public until the matter itself has been specifically included on the agenda and our action items pursuant to the NRS on your screen. Ms. Rodriguez, do you mind going over how folks can dial in from the telephone, please?
Sure. So if you are dialing in from a telephone, please dial 669-444-9171. And then when prompted, you will enter the meeting ID, which is 825-0031-7472. And then please press *9 so that the host can prompt you to unmute.
Wonderful. Thank you so much. Ms. Rodriguez, do we have anyone for public comment?
Chair Johnson, I do not see any participant indicating that they would like to provide public comment at this time.
All right, wonderful. I do see a few folks who are unmuted on the meeting, so I don't know if they're unmuting to raise their hands for public comment or just available. I'll hold for one moment. All right. Hearing and seeing none, we'll move on to agenda item number 3. Agenda item number 3 is to review and approve the minutes from our September 21st, 2023 Prevention Subcommittee meeting, which feels oh so long ago. Hopefully, committee members have had the opportunity to review these minutes in advance of the meeting. If so, I'll entertain a motion for approval of the September minutes.
So approved, Madam Chair. This is Eric for the record.
Thank you, Vice Chair Schoen. Do I have a second?
Second, this is Debbie Nadler for the record.
Wonderful. Thank you, Ms. Nadler. All in favor of approval of the minutes from September 21st, say aye.
Aye.
Aye. Any opposed? And any abstentions? All right, wonderful. Our minutes for September have been approved. With that, let's move on to agenda item number 4, which are the 2023 recommendations from the October SURG committee meeting discussion. Ms. Rodriguez, I know you've done quite a bit of preparation with the SEI team to organize the feedback that we so graciously received from our other subcommittee members. Would you like to introduce us to your process that you have outlined here today?
Sure, thank you. Emma Rodriguez for the record. So on the following slides, we have all of the recommendations that were remanded back to the prevention subcommittee from that, I believe it's October 11th. I'm going to put Angela back on mute, unless were you trying to say something, Angela?
No, sorry, I'm having a day. Sorry.
We're glad you're here. Thank you. So I don't know off the top of my head how many there were, but I think it was about 4 or 5 recommendations. So on the following slides, we have what the language is, and then in bullet points, what the conversation was about each recommendation during that October SURG meeting. So I think the idea would be for the prevention subcommittee to take that feedback into consideration and then determine whether they want to further workshop the recommendation live. If somebody wants to volunteer to take that on and bring it back to the full SURG for the December meeting, or if they want to leave it as is and send back to the SURG, wherein everything will be voted on again in the December meeting.
Terrific. Thank you, Ms. Rodriguez, and to you and the team for putting these together for us. So let's go ahead and look through the first recommendation that was put back to us for review. All right, wonderful. I can see the PS1 recommendation at the top, and then some of the commentary regarding why it was remanded back to our subcommittee meeting. So, so the recommendation is around to DHHS, DPBH, and the Bureau to double the amount of investment in primary prevention programming every 2 years for ages 0 to 24 and review the funding allocation annually. Chair Ford and Assemblywoman Thomas supported this remanding so that we could get an estimated budget for legislators to consider. That Vice Chair Lee agreed that we wanted to include some fund mapping from DHHS for allocation for prevention programming, and that we'd work to incorporate some of the cost effectiveness data that was included. So I did. I wanted to just, I know we have some folks on the line from DPBH who can maybe help to move some of the funding discussion forward. Or could help us estimate the current budget potentially, or a fund map. Curious if there are folks here who can add to that conversation. Mr. Schoen?
So I just sort of looking at Emma to think if you would agree, this would be a good direction. So yes, I was provided a copy of a fund map, and I think Emma, you sent it. I don't know if anybody else, but I did a little bit of work on it to make sure there were subtotals at the bottom. I don't know, Emma, if you have that one or if you want me to share that one.
Yes, Emma Rodriguez for the record. So we did send out the fund map that was provided by SAPTA. It's also posted to the SURG website, so it's available to the public. I believe Eric had requested to have the totals produced at the bottom, but there was not enough time for SAPTA to do this and get it approved. So if it's all right with Abe, I can show the version that Eric then edited himself as a draft. But just note that the totals haven't been double checked by SAPTA. So I can go ahead and share my screen if that works.
I let me just say, first of all, I really appreciate the work. My adding the subtotals was not meant to detract from which I think you guys would agree is a really good document. So it's very helpful for me. The only thing I was missing were those subtotals, so we could kind of compare what's going to prevention, treatment, so on and so forth.
Let me share my screen.
And I will say I did run all of my totals twice through the calculator. So we have, I know that's not another person, but I didn't just do one run through and take the numbers as I put them. I made sure I got confirmation at least twice.
you all see that okay?
It's very small.
Mhm.
See how I can. So I believe this is.
Yeah. Chair, if might I start this a little bit? Okay, so when I noticed when I did the subtotals at the bottom, what I see going to projected estimated year one budget for prevention is 6 million and some change, compared to treatment of 10 million and some change, compared to and that doesn't include the women's portion of that. So you would add an additional 1.8. So you get about 12 million there. And then recovery is a little over $1 million. So for those who are wondering how prevention is funded relative to others, Lisa Lee's comments that she thought prevention was well funded relative to recovery that's an astute comment. There's a little over $1 million, it looks like, going to recovery and 6 million going to prevention. I think, so where I stand, I'm not sure I care as much about what is going into each of the other pots. Our charge is as prevention to highlight the importance of prevention and the impact that prevention programs can make. And those other committees are able to make recommendations for increasing the size of the funding that should go to those funding streams as well. And I think there's an argument to be made that all of these are underfunded, tremendously so, in terms of what we could do if we just had the funding to really invest in some really, really good programming for a long, long time. It would be really interesting to see what we could do with the numbers and people's health. So from my, and Abe, you correct me if I'm wrong, but if I'm right with those totals and we're at about $6 million per year for prevention, then that gives me an easy dollar figure to double to 12 million and say we'd like in the next time that this budget is approved, going from 6 million to 12 million for the state's share of prevention funding. Is there anything with that line of thinking that's off track? I mean, there may be some things I don't know which entirely likely possible, but is the rationale on that solid?
This is Jessica Johnson for the record. The rationale on that makes sense to me. Vice Chair Schoen, your comment regarding sort of relative to other funding categories also makes sense to me. I do see Ms. Hale from SEI has her hand raised.
Thank you, Madam Chair. I just wanted to mention that it looks like the spreadsheet that Abe Meza provided is SAPTA funds. So it doesn't necessarily include funding that might have gone out of the director's office or possibly other divisions within DHHS. So I just wanted people to be aware that this is not necessarily all the funds that come out of there. And Abe can clarify that too, probably.
Thank you, Ms. Hale. Mr. Meza, would you like to make a comment on that?
Yes, this is Abraham for the record, Abraham Meza for the record. Ms. Laura Hale is correct. This is the money that we are directing directly from SAPTA. This is just our allocations, not allocations for the whole entire state. So that could include TCFS and other entities.
So could we refine our recommendation for SAPTA funding to be doubled so that we don't conflate the total with any of those other funding streams?
Mr. Schoen, oh, sorry, go ahead.
Sorry, you go ahead.
I was just going to say, I think we could clarify that it could be specific to SAPTA and perhaps could encourage the SAPTA to, it doesn't necessarily have to be just these dollar amounts, but to explore sort of other funding sources that might help achieve the recommended doubling.
Mhm.
I do see, oh, sorry, finish your thought and then I'll go to Ms. Nadler.
Again, I want to be really clear that this would not cannibalize any of the fund. I mean, this should not be at the expense of any of the other funding that's currently being allocated for recovery, women's services, or treatment. If the way that this is accomplished is by sweeping those accounts, then we've lost. So this should be above and beyond what's already allocated in my mind.
I think we probably need to add a statement to encapsulate that at the end of this. Double the investment, like not at the expense of existing programming or something to that effect. Ms. Nadler?
Thank you. Eric, I agree with you 1000%. I do have a question, and I'm sorry if I sound ignorant on this, but I see the funding, I see everything, but do we have an actual list of programs being done right now? Because I have searched high and low all over the internet, everywhere, called schools, trying to find out what they're doing. And I think it would help. I mean, I know it would help in my mind to see what exact primary prevention programs there are with all these dollars so-called being allocated, because our as we all know, we have more and more kids reaching out to use more and more overdoses, and I'm not seeing anything in the schools unless I'm completely blind.
Thank you for your comment, Ms. Nadler. Sorry, did you have something else you wanted to add?
No, well, the other thing is in Reno, truly, I see they are doing a lot in the schools. There's a lot more being done than there is in Clark County. And again, I don't want to compare the different cities and what's going on, but if you look at Reno and what they're doing and look at our schools, it seems they're going kind of above and beyond of what's happening in Southern Nevada.
Thank you for your comment. Ms. Rodriguez, I was under the impression that our SURG prevention subcommittee was working to get a list. Do you recall the status of that list?
So Emma Rodriguez, for the record, I'm going to turn it to Abe. I believe that they were working on the list, but it has not been finalized. Is that correct, Abe?
Yes, this is Abe for the record. You are correct. We are still working on finalizing that. We should get that done this week, I believe.
Terrific. Thank you both. So Debbie, I know the Bureau had been working on a list of programming, so that should be coming soon of what types of programming are happening. Thank you for bringing that, elevating that back up for the group.
Thank you, Jessica. Thank you.
I noticed, so the chat is not usually used for the public in these types of circumstances, so I'm just going to vocalize one of the comments from the chat from Vanessa Diaz did say that there was a recent NOFO put out from the Fund for Resilient Nevada focused on youth programming specifically. So for folks who are on the call and interested in that, that is available. So far in workshopping this recommendation, I was hoping to move back to that. Mr. Schoen, did you have something else you wanted to add?
I think the only thing I'm reviewing the language here for what, and I appreciate Emma, you editing this in live. The only thing missing is sort of a dollar figure, like what it is doubling too aggressive. It would be better to say increase by 50% to minimum of 9 million a year versus 6 million a year. So that's the only thing that I'm playing around with in my head.
Yeah, Thank you, Mr. Schoen. As we come up with that number, I do think that part of our recommendation was an estimated budget. I did follow up on my comment regarding cost effectiveness, so I'm just going to read this out so it can be included in future notes for the SURG. So the National Drug Control Strategy, so that's a document out of the White House and their 2022 release of the National Drug Control Strategy, has a section on the effectiveness of prevention and the cost effectiveness. So some of the areas that were noted in this particular report are, according to the 2016 Surgeon General's report on alcohol, drugs, and health, it's noted that prevention science demonstrates effective prevention interventions exist and can markedly reduce substance use, and evidence-based programs and policies are underutilized. So both things that go towards supporting the implementation of this particular recommendation. They cite multiple examples of the cost effectiveness of some individual programs, but overall, they said, for example, the average effective school-based prevention program is estimated to save $18 per dollar invested. So I thought that that was a helpful, supportive point for this particular recommendation, that over time it should result in a cost savings for the dollars that are estimated in terms of or invested in terms of outcomes. Some particular, they mention other like specific individualized programs that are also evidence-based, in some of the specific language, or sorry, the specific cost benefit ratios associated with those. But I just thought that the $18 per dollar invested was a helpful ratio to start with, and was hoping we could include that in the follow-up assessments when we report back to the committee. Ms. Nadler, did you want to add to that?
Yeah. Yes. Thank you. So in the primary prevention, are we focusing also? Are we putting the mental health, the social emotional learning, the needs for our children as part of that too? Because we can't even put a price on a life, right? We can't. There's no dollar amount we can put spending per kid to get all of this into the schools. I'm sorry. I'm sorry. I'm not having a good day, and I'm very upset about what's going on through the country right now. And I just think it's so important that we have this prevention, this mental health, the social emotional learning in the schools, because it all goes hand in hand with substance use and all of it. It's so very important.
Yeah, thank you. Thank you for elevating this, Ms. Nadler. I appreciate your voice here. My understanding is that that's particularly why these prevention programs aren't necessarily seen as substance specific. They really work to address risk and protective factors, and many times those programs do have outcomes not only for substance use, for mental health, for teen pregnancy prevention, violence prevention. So really work across the outcomes of these programs and how they're studied. That's part of the reason why they're thought to be evidence-based, and why that's leaned upon, I think is the correct way to say that, because they do have a variety of outcomes when they're not necessarily targeted to a single substance and raising knowledge about that particular substance, when they're skills based, when they're addressing ACEs and those types of things. So to your point, that's, I think, why this particular recommendation is focused on expanding that reach with funding, and not prescriptive in what a particular prevention programming would be, so that it can work to diminish risk factors and develop social competencies or protective factors as it relates to the various communities across the state. So thank you
What,
for elevating that.
yeah. So in part what Eric was saying, sorry, this was a two-parted thing. I think if we reach for the stars and take the moon, that would be good too. So I don't see, in my opinion, any harm in asking for double the amount as opposed to less than double. Because if we ask for more and get less, okay, we get less, but at least by us asking for more, then perhaps we might get it.
Thank you, Ms. Nadler. I appreciate that. Vice Chair Schoen, I wanted to add that perhaps because the figure that we have in front of us right now is approximately 6 million, maybe we can use that as our baseline amount. What are your thoughts on how to wordsmith this?
That's my thinking as well. And then the other thing too, I just remember our recommendations are all advisory. There's nothing compulsory about the recommendations we make. So I think that's another reason we can come out of the gate strong. Sending them, I mean, basically what we're doing by setting such an ambitious goal is underlining how important it is to think about prevention and not have it be an oversight. So yeah, I'm comfortable with using the benchmark of 6 million and going to 12 million for SAPTA. At a minimum of 12 million. If they want to do more, great. But yeah.
Thank you. Do we need to change anything with the language around every 2 years in this?
No, good
Recommend
point.
to
I
double
think-
the amount of investment in SAPTA primary prevention programming.
I think we do, because then in 2 years after that, if they double it again, it would go to 24 million. So I think what we could put in parentheses, it would be 12 million for the next biennium, whatever, and specify that biennium, i.e. 12 million for this biennium. And then we can revisit this next 2 years from now and decide if we want to keep the pedal to the metal and go ask for another 100% increase or back off.
Yeah. Thank you for adding that, Emma and Mr. Schoen, for your thoughts. Do we want to say something about the baseline dollar amount in here?
So increase from the current 6 million, increase from the 6 million per, I think this is 6 million per. Hey, can I ask Abe a clarifying question?
Please do.
That says 6 million for year one. Does that mean there's 6 million also for year two?
So we try to allocate biannually, but we reassess halfway through that to reallocate money. So at this time, that would be our total cap.
The 6 million would be your total for both years.
Mm-hmm. Well,
Okay.
for the first, yeah. Sorry about that.
Okay. All right. So then, yeah, I think 12 million. So increase from 6 million from the current biennium to 12 million for the next biennium.
So after the IE, okay, perfect. Thank you, Ms. Rodriguez, for typing on the screen what I was about to say out loud.
I also wanted to say, Chair, thank you for doing that research. I know that there's a lot of data out there that supports the efficacy of all of these prevention efforts, and to find, again, current data that supports that. And actually, for every dollar spent, 18 saved, that's a huge return. And again, I think it underscores, if we can help to encourage our decision makers to think about really investing in the base of the pyramid, I think we could have, we could really revolutionize how services are accessed, how protective factors are enhanced, and hopefully see a dramatic change in people who have a heightened risk to any harm from substances at all.
Thank you, Mr. Schoen. Ms. Nadler, any final comments on this?
Yes, I love what Eric just said. I wonder if we can perhaps in this new draft that we're writing, we put something saying why, something of what Eric's words were, just justifying the reason why we're asking for that. Eric makes some valid points there at the base of the pyramid, and maybe if we say why and present that in there.
Thank you, Ms. Nadler. I know the SEI team is recording, so if we can add the research discussed and some of the rationale to the justifications and background section, I think that would help strengthen this recommendation as well. Thank you both. Wonderful. I think that we have addressed the subcommittee's recommendations, broadly speaking, for this particular prevention recommendation. So I'm hopeful we can move to the second one, if that's all right with committee members. All right. Wonderful. So this is our second recommendation. It's around allocating tobacco control and prevention funding using a local lead agencies model to reach $2 per capita. Recommended funding using a combination of funding sources that are on your screen here. Chair Ford, his rationale for remanding this back to our subcommittee was because there are certain rules related to tobacco funds that one of the DAGs could review, which I think is on the next slide. And then I know Ms. Nadler is hoping for a marijuana or cannabis presentation. We're working to schedule that in 2024 with our previous presenter to move that piece forward. I would be curious if we can move to the next slide to see what the DAG's recommendation is. So the comment by the Tobacco Enforcement Unit's Senior Deputy Attorney General mentioned that the AG's office does not control budgets related to this particular recommendation. And then for reference by statute that all money received by the state pursuant to any settlement entered into by the state and a tobacco manufacturer or recovered by the state from a judgment or civil action is split between the Millennium Scholarship Trust Fund at 40% and the Fund for a Healthy Nevada at 60%, with the particular NRS codes included. That the state treasurer administers the funds and cigarette and tobacco product taxes are administered by the Department of Taxation. So given this, I'm wondering if we want to workshop this particular recommendation. I had some initial thoughts, but was curious if the subcommittee wanted to weigh in before.
For the record, Chair, I'd like to hear your thoughts.
Okay, wonderful. So one opportunity would be to take this in a different direction around creating a bill draft request to the legislature. So perhaps because okay, let me talk about my rationale initially. I reviewed briefly these NRS, the NRS that's listed here, and it does seem that so not touching the dollars allocated to the Millennium Scholarship Fund, but within the Fund for Healthy Nevada, what I learned was that they're overseen by a group called the GMAC, who allocates funding for various different organizations across the state. And some of those are tied to tobacco prevention and control, but not necessarily. That there's a variety of projects that are funded across the state from this particular fund. So from my understanding, that the tobacco prevention and control groups in our state compete within this Fund for a Healthy Nevada across the board. So one thought that I had, which could be very unpopular depending on who's on the call here, but would be to instead move to create a bill draft request to the legislature that amended the NRS and created a direct line of tobacco prevention funding from not the Fund for a Healthy Nevada component, perhaps around 10%, that would be allocated using this local lead agencies model that's recommended by the tobacco prevention and control groups and work towards reaching this $2 per capita for tobacco prevention and control.
So, Chair, thank you for those thoughts. And I like where you're going with this, because really the intent, I think, of what we're trying to do is make sure that there is dedicated tobacco prevention funding that doesn't get cannibalized or sold short by reallocating for other priorities, as a way of underlining too that this is really an important component of overall prevention. So I'm loving the specificity of what you're recommending. I don't know about the numbers or those sorts of things, but I think you're onto something here.
Thank you for that feedback, Mr. Schoen.
I agree, Debbie Nadler, for the record. Yeah.
And I'm noting that recommending bill draft requests are within a purview of where the SURG SURG recommendations can come from, and that it would move perhaps away from some of the concerns of the AG and the debt and the comments from the Senior Deputy Attorney General to address this.
So 2 questions. If we went with a number of, let's say, 10%, do you have any idea what that would work out to?
I didn't get a chance to do the back of the napkin math in advance of today's meeting. But I don't know if there's a SURG subcommittee member who would be willing to do that in advance before this gets presented to the larger SURG in December. I imagine that will be a question of how close it gets us to this $2 per capita recommended funding.
That was the same question I had. Maybe 10% overshoots it or it undershoots it, but whatever would equate to $2 per capita could be the percentage that we recommend.
Yeah, I can volunteer to try to get that figure for presentation purposes. But we wouldn't have a chance to review that talking point in advance of the December meeting. Is that something the committee is comfortable with? What are your thoughts, Mr. Schoen?
Yeah, so yeah, I'm comfortable with that. I mean, if what we're agreeing to here is that the principle is trying to get to this $2 per capita, and so whatever percentage you end up recommending, whether it's 5% or it's 15% or 10%, is going to equate to that $2 per capita, then I think that is a supported ask, because that's what's recommended, as I think national best practice, if memory serves. So we have that as our rationale for why we're asking for that percentage.
Yeah, and the $2 per capita is what's recommended by the state tobacco control, prevention and control coalition group that would help move us out of, I think, 50th percent for funding and into more of the middle of the pack.
Yep, right. So I think that's a solid ask and solid approach.
Okay, thoughts. Thank you, Mr. Schoen. Thoughts from other subcommittee members? Oh, sorry, Laura Hale, go ahead.
I was just going to mention, Chair Johnson, that same group that you just referenced is recommending, for the state group that recommends the $2 per capita, they may have done some of the work that you're proposing to do, so they might be able to give you that answer.
Fantastic. Thank you, Ms. Hale. I'll reach out to Mr. Allo, who gave us this presentation, to see if he has has already calculated out these costs to see how close this would get us to the $2 per capita. And then move forward with the language around a bill draft request, inserting the percentage amount that is associated with a figure that would get close to the $2 per capita. Any additional thoughts from the committee on this particular recommendation? Seeing and hearing none. We can move on to harm reduction recommendation number 4. I think that's the next one. Wonderful. Thank you, Emma, for moving us forward here. So this is so we completed the workshopping of the prevention specific recommendations. So now we're moving into the harm reduction recommendations, which our committee has been voluntarily workshopping. Thank you all on behalf of the larger SURG. For this particular recommendation is around a bill draft request at the legislature to change the language around drug paraphernalia as it relates to smoking supplies. Chair Ford remanded this as he thought it would be too big for a bill draft request, and Assemblywoman Thomas agreed, and that they were remanding to the subcommittee for additional detail. I am opening this up for discussion. If I did a little bit of background research on this in advance of this meeting, but would be curious if other folks on the committee have thoughts before I share that.
Chair, you were, for the record, Eric Schoen, you were anticipating my lack of knowledge here. I'm shooting in the dark on this, so any information you could provide would be helpful.
Wonderful, thank you. I'm broadly going to recommend that that there's an opportunity for us to model some of this language after the Assembly Bill 345 from the 2021 legislative session. This worked to exempt testing equipment for overdose prevention purposes. Sorry, it's 345, Emma. So I think that we have something to build on in that regard. And in my brief research in advance of this meeting, it looks like both Washington State and the National Association of City and County Health Officials, or NACCHO, have a few recommendations for how other states and localities have been approaching this particular language, especially as it relates to the rise in fentanyl overdoses. If the committee is in agreement, I'm happy to take this on as homework to workshop some additional details and additional specificity for this particular recommendation, and with the goal of bringing something more specific based on this information to the December meeting. I'm open to thoughts from this group based on that.
Well, so Eric Schoen, for the record. So first of all, there's something about that acronym that makes me hungry. So I would love that we pronounce that nacho. I don't know if that's accurate.
You're not alone.
Secondly, can you give any of the examples now? Because I'd like to know sort of what that looks like.
Yeah, so the states who have had this, from my brief understanding, have implemented this differently. So for example, California's language around drug paraphernalia as it relates to smoking supplies is very broad. So each individual public health entity across the state can determine, based on what they're seeing in a particular region, what supplies are deemed to be paraphernalia or not. So it can be a little bit more broadly specified and determined based on public health need. Other groups and jurisdictions, I think Washington, D.C. is another locale that recently changed their statute on this topic, are more specific to types of supplies that are allowed or where folks are able to access them, if they're from harm reduction organizations, for example, or other types of entities. So my plan was going to be to refamiliarize myself with some of those approaches and take a stance that really centers on overdose prevention and opportunities for the legislature to consider something broad enough that they wouldn't have to be going back to amend time over time, yet specific enough so that it could be for overdose prevention purposes.
Thank you for that. I appreciate that. I appreciate you taking the lead on this, because it's not an area of expertise for me, but I would just sort of broadly sort of thinking. So I like that overdose prevention is one of the top determining factors about whether or not we'd make a recommendation. But also, I would say destigmatization. If we can accomplish that in our recommendations as well, that would be really helpful.
Thank you, Mr. Schoen. I was also remiss in adding about bloodborne pathogen prevention as well. So things like the sharing of smoking paraphernalia can increase one's risk for hepatitis C or other types of infectious disease. So in addition to overdose prevention, adding some of those bloodborne infection prevention transmission areas.
Perfect. I think that's a strong 3 to sort of use in evaluating what we might bring forward.
Thank you for that input. Other thoughts from committee members or suggestions for additional details here? All right, seeing and hearing none, I'm going to move on to the next recommendation. So this is harm reduction recommendation number 2. This was around harm reduction shipping supply. The committee will recall that this was one we asked for additional feedback from committee members for workshopping and for adding justification, background, and the qualitative elements. And Ms. Cheatham volunteered to help workshop this particular recommendation and shared this with the committee in advance of the meeting. So we can go to the next slide, if that's okay. So this is based on Ms. Cheatham's input, who worked very closely in standing up this initial program in collaboration with Track B Exchange. So you'll see the original language at the top, and then Ms. Cheatham's recommended language is to provide for shipping costs for harm reduction supplies and for travel costs for the pickup of used Sharps products to be returned for destruction, increase advertising about shipping programs in rural Nevada, and in collaboration with local agencies and through community conversations, establish local support for harm reduction efforts. Establish an alternative strategy for harm reduction supply delivery if people can't receive delivery of supplies directly. This is her updated language. Thoughts from the committee on Ms. Cheatham's updated language here?
I really appreciate her taking the time to do this. This is a strong recommendation with a kind of specificity that I think gives it more teeth for raising the likelihood that we can move forward and have something actionable. I don't know if it needs to be refined any further, but I really appreciate Ms. Cheatham's work on this.
I would agree with that. Thank you, Mr. Schoen. Go ahead, Ms. Rodriguez.
Thank you. Emma Rodriguez for the record. I did want to note she also provided additional justification and background, and as well as those qualitative elements, which I have on the following slides. So I wonder if it might be helpful to review that first and then potentially come back and see if there's any changes you want to make to the language.
Thank you, Ms. Rodriguez. I think that would be a great next step. So here are some of the justification and background regarding the availability of syringe exchange and harm reduction programs and the current service area of Track B Exchange with some helpful data points around current requests receiving and the shipped naloxone in particular that they've been able to expand. And then slide 15 includes some details around those qualitative elements around impact, capacity, and feasibility. I'm noting here that they're working with Next Distro to ship supplies, but could be supported to allow for growth across the state. Next Distro is a national program that many syringe service programs work with, so reputable and increases the feasibility. And then just briefly slide 16, if you don't mind. This also increases around the urgency and the support for addressing racial and health equity.
So for the record, this is Eric. Can I just sort of talk out a couple of examples to show that I think community acceptance around this is really increasing, and this is blowing up in a good way. Some of you may know that I helped to head up a couple of different statewide coalitions, Resilient 8, Formidable 14. And I want to share a story from one of our community health workers who serves Wendover. We have employers who are reaching out. One large casino out in Wendover asked that this particular employee provide naloxone training for 240 of its employees. They had her present to groups of 80 groups of 80 employees to make sure that everybody in that organization, or as many people as possible, were trained up on naloxone. We are having entire school districts throughout. It's no longer sort of, should we or shouldn't we? It's like, no, we need to. We have entire school districts who are asking for us to help train up their school personnel. There is not the resistance that there once was, and there's more of an acceptance and recognition that this just needs to be a basic part of the arsenal of tools that we have available to help keep people as safe as we can. So I think this is everything that Ms. Cheatham has put in here in terms of expanding access. If anything, I think now we're almost on the side of the equation where people would like to have more naloxone available, and so that we could saturate the state with naloxone and not be worried about where we might be able to get it if we need it.
Thank you for those comments, Mr. Schoen. Based on this information, can we briefly go back to the slide with Ms. Cheatham's updated recommendation? I just want to hold a moment here in case committee members have additional information they'd like to include in this proposed updated language. I see Debbie's hand. Go ahead, Debbie.
Oh, on this recommendation, for her recommendation's great. I'm so glad she did this. But I'm wondering if we need to put examples of the harm reduction supplies, like, naloxone, needle exchange. Do we need to put that wording, what it is, in there?
I am open to what the committee thinks. I think there's opportunity in keeping it broad for communities to update sort of what their needs are based on the emerging drug threats. I also think sometimes folks can be benefited from additional examples. So I'm open to direction from the committee.
Well, can it be a both and?
Yes,
Say
of course.
Examples include, and then this is not to limit other emerging strategies or possibilities.
That's good. I like that.
Yeah, so is your recommendation then, Ms. Nadler, to add it after that harm reduction supplies, so sort of e.g.
Yes.
Naloxone, sharps, fentanyl test strips, etc. And then can we add in the not to be limited by statement that Mr. Schoen said earlier so eloquently. Not to be limited to, or maybe e.g. these, but not limited to.
Other harm reduction supplies, something. I'm not a wordsmith, but.
Myself either, Ms. Nadler. Yeah.
Does
Thanks,
that
Emma.
work? Or I was trying to get to what Eric was saying about or maybe it was you, Jessica, that was saying that about what the community
Identifies.
Well, I'm sorry, Eric, for the record, if I can jump in. I like that we don't want to limit their options to only current technologies, because we may have emerging technologies. What I've seen in terms of the decisions made by some of the local counties, in terms of allocating, for example, settlement dollars, is that they've gone to questionable purchases that aren't necessarily prevention related. So you can look at that. If we give them too much wiggle room, I'm worried that local political decisions, budgetary decisions could maybe have them make a determination on how dollars should be spent that really aren't harm reduction. Does that make sense? So I don't know how to word this with the kind of lanes that we would want to keep it clear and on track. I'm at a loss right now.
No, this is Jessica Johnson for the record. I couldn't have said that better myself. So perhaps leaving it at etc. is a helpful middle ground for now, or we could talk about shipping costs for evidence-based harm reduction supplies. Might be another route to think about.
Mhm. Some of this is not so easy, you guys.
I'm very grateful for this committee for taking on workshopping, especially these areas for many of us that are tangentially related to our areas of expertise as well. So,
Yeah, there's probably not a perfect way to word this. All we can hope, kind of clearly leave a clear breadcrumb trail about the rationale and what we're hoping, and hope that others follow in the spirit of that.
yeah, agreed. I am comfortable with this proposed
Mhm.
language as is. I do think that it covers some of the reasons for the remanding back to subcommittee as well, with Ms. Cheatham's proposed updated language. So kudos to her hard work here.
I am as well, especially with the addition of the term evidence-based.
Debbie Nadler, for the record, I like this.
Thank you, Ms. Nadler. Wonderful. Thank you both so much for this. In the spirit of that, I think we have maybe one more area to discuss for the remanding. Wonderful. This is harm reduction recommendation number 5. So this is provide support to community coalitions to support community health workers and expand harm reduction throughout the state of Nevada, and prioritize funding for community health workers to provide community-based harm reduction services. Initially, the discussion at the larger SURG was to remand this to the Treatment and Recovery Subcommittee to combine with one of their recommendations. But at their meeting last week, they determined to not combine this with their recommendation and rationale. I think specifically theirs is focused on peers, and this one is very focused on community community health workers. In some of that discussion, it sounded like from their perspective, community health workers were really sort of at that kind of case management community level, where peers or peer recovery support specialists were individuals with lived experience as part of their history and work. So wanting to bring this back up to see if it is a recommendation that we would still like to move forward to the larger SURG in December, and if so, if we have any further changes or details that would be helpful to include here.
So Eric, oh, go ahead, Debbie, you go first.
Debbie, if you're speaking, you might be on mute.
I was, thank you. It the way I'm reading it just seems so broad. I mean, if we're going to take it on, is there perhaps a way to narrow it down? It just seems so broad to me.
Yeah, that's an excellent point. Mr. Schoen, what are your thoughts?
Oh, this is hard work. Well, just a little bit in terms of, I think going back to where this originated from was to not lose sight in investing. Again, I mean, similar to our first recommendation of including prevention funding from 6 million to 12 million, that we have these, I think, paraprofessional levels, including peers and community health workers who have historically been underfunded, underinvested in, and we're seeing them do amazing work for really connecting with consumers and residents on the ground level, providing the kinds of support for a lot less money than what we used to think we had to do, with a lot better overall outcomes, I think. And so the idea that community health workers would be part of the team, just as peers are, with harm reduction, I think is that was sort of the principled place that we were coming from. In terms of, and I'll go to part two, I did read the rationale for the treatment committee to want to keep these as separate, and I respect that. They're really trying to raise the profile of peers, and I think there's a concern that if I'm reading between the tea leaves, there's a concern that they get diluted by being included with community health workers, and that was never my intent. My perspective is informed by being a licensed professional counselor that moved from Oregon nearly 30 years ago, and I lost my license because it wasn't yet recognized here in Nevada. And over the decades, developing a really good working relationship with MFT so that we could join hands and work together. And that once we got to that point, we were able to basically advocate for each other. We're basically, whether we like it or not, siblings. And so rather than sort of fighting over turf, which is kind of what it was for a while, recognizing that we were each other's best advocates, and that we were stronger when we joined hands. And so that was the perspective I was coming from, that community health workers have made some significant progress in the last biennium for Medicaid reimbursement. And I didn't want peers to be left behind. My colleagues who advocate for peers have really helped me understand that I need to be an advocate for peers as well. So every time that I mention community health workers, I try to mention peers, not saying that they're the same thing. They can be, but they're not necessarily the same thing. And you can have community health workers who are also peers and providing those services with the same nuanced perspective and informed by their lived experience. And so the idea was really sort of saying, hey, let's, rather than thinking of this as chicken or egg, that we would recognize that these are both basically siblings and that we'll be stronger if we can somehow find a way to work together. It wasn't to take the spotlight from peers, but I completely respect that. So anyway, that I just wanted to get that on the record as well.
I really appreciate that, Mr. Schoen. I know you've been in this work for a long time, and really looking at ways that folks can, work smarter, not harder, work together in many of these ways to build up that network of support. I think for me, this is sort of out of my wheelhouse in terms of how to think about what to do with this particular recommendation. Do you have any initial thoughts on do you think there's a framing around like support, as you were just mentioning, to the peer recovery support specialist certification, and where there's an opportunity for dual certification with a community health worker to elevate that?
Well,
Do you recommend that we, it's a little vague to Debbie's earlier point as is, so really open to how to operationalize this.
Yeah, me too. I go back to that first sort of instinct of just saying, hey, folks, when you're making decisions, whoever the decision makers are, when you're making decisions, remember that community health workers and peers can be a vital, or should be probably the primary workforce working on harm reduction. I don't know how to operationalize that either, to tell you the truth.
Yeah. I'm recalling some of our discussions from earlier this year that this came about where in a community there might not be peer recovery support specialists, but there is a network for community health workers, if that's an appropriate entity for supportive of linkage for individuals.
Well,
So
and just to
sorry.
build, no, and to build on that, in rural areas, sometimes peers are not yet as socially accepted as community health workers are. And so in some ways, the proverbial camel getting the nose under the tent so that can eventually become completely into the tent. Community health workers provide us that entree point. And then once folks get familiar with like, oh, that's what you're doing? Yeah, we're totally fine with that. We're able to oftentimes then breathe life and also peers having a more active vocal role in those communities. So that's why I see these as so complementary. And but again, I don't know how to. I completely respect the treatment committee's recommendation for keeping it separate. I'm just not sure how to translate that for this, but I do think there's utility in somehow suggesting, highlighting that community health workers have a presence.
Yes, thank you. Before I go to you, Ms. Nadler, I also wanted to add that my recollection in our discussions with this recommendation were also about if feedback that I've heard from some community agencies is that folks who are peer recovery support specialists may not be comfortable working in harm reduction services based on their recovery journey or experiences. And so this provided an additional enclave for individuals to help support particularly community-based harm reduction programs, not in lieu of peers, but if people were hoping to engage a paraprofessional type model in hopes of scaling some of this work up for more like a peer navigator type of approach. So wanting to just elevate that as well. Not sure that it gets us any closer. Maybe Miss Nadler will help us get there. Miss Nadler, go ahead.
I doubt it. Perhaps, is there some kind of wording that we could add, kind of how we did the other one, like define community health workers, give examples of in there? And maybe perhaps, because what Eric said was so important, the peer specialist, maybe perhaps somewhere add in there working dually with the peer recovery specialist when available, or just, I don't know, break it down, the community health workers, like, who are they? The community coalitions,
Yeah, thank
or
you, Miss
given
Nadler.
examples. But other than that, I don't have an answer for how to do this.
Yeah, thank you, Miss Nadler. I appreciate that. At least attempt at getting a little bit more specific as we think about this, and perhaps it is framed as a support to a peer recovery support specialist model, or as you mentioned, working in support with PRSS. when available. Go ahead, Mr. Schoen.
Yeah, so I could tell you how peers being co-credentialed as CHWs is helping to advance peers and provide sustainable funding. Those peers who receive that credentialing can then be in line for Medicaid reimbursement funding for their services. And so, again, not an either or. This is something that can directly support the expansion of peers. And so whether they're called community health workers or peers is almost sort of something that we like to do on our end, but on the receiving end, it really doesn't make as much of a difference sometimes as maybe the distinction seems to be.
Yeah, thank you for that. What does the subcommittee think of amending this around so provide support to peer recovery support specialists to expand to around sort of the dual certification as a CHW? So it's framed less as support to community coalitions, but really supporting the PRSS certification with an expansion to CHWs.
Well, in my mind, by the way, this little bit of a sort of head start that community health workers have on Medicaid reimbursement is hopefully only temporary. I would love to see peers have equity for that in the next biennium if there's somebody who would carry that bill. I really do think that these guys, CHWs and peers really are the two most aligned, and that if we can recognize that we're all part of the same team, we'll be able to advocate for the advantages of both and the attributes of both. So not sure again how to wordsmith that, but yeah, anyway.
So to that point, would you support, I guess, a complete revision of this around recommending a bill draft request to elevate or to equalize the peer recovery support specialist with the community health worker?
Yeah, so that is on par or equal to or exceeds what the CHWs currently have worked out for Medicaid reimbursement. Absolutely.
Yeah.
That would be helpful for sure.
And maybe that increases the specificity of this recommendation. It supports the work of peers to equalize peer recovery support specialists, so it's equal or exceeds like CHW reimbursement.
And I only use that as a benchmark because my understanding of the CHW reimbursement is that it's not bad. It's actually close to livable wage kind of reimbursement. So there may be a better benchmark, but it seems like it's a good place to start.
So I like this section. I'm wondering if we could entertain an educational requirement to both around evidence-based harm reduction.
Mm-hmm.
There are different categories of educational requirements for each of these certifications, and I'm wondering if something more formalized would be a helpful way to support both certifications.
So the hope would be that any area of quote expertise that I'm operating in as a pure community health worker, that there would be the ethical corollary that they would be trained in those things, right? And that's for me sort of a basic assumption of this working at all. And that for me comes from my professional ethics too, that I'm not supposed to provide any treatment that I don't have training in or experience with. And so I would hope that there would be a similar, I think there is similar expectation of peers and community health workers to be likewise trained, whether it's diabetes management or it's harm reduction, that they would make sure to have the training and experience.
Yeah, thank you, Mr. Schoen. Ms. Hale, did you want to add something to this recommendation?
Thank you, Chair Johnson. I was at the treatment and recovery meeting where they discussed this and decided they didn't want to combine them. And I just wanted to give you a little background about that. So one thing that came up was that while there are similarities between the two classifications, the peer recovery folks, that's the main thing, is that they are peers and that they're not coming from, some separate experience. And they also, I think what you guys are driving toward is the classification and, trying to make this comprehensive for both classes to move forward. And I think, so the Treatment and Recovery Subcommittee got presentations from people who are doing PRSS and people who specifically wanted to say, we want to move this forward as a separate thing from community health workers. And so there was a lot of discussion around that at their meeting on October 23rd. And so I can't, forecast what they're going to say at the SURG meeting, but I just wanted you to be aware of the conversation and how that came about, that they did not want to combine these because they really see them as two separate things. And so the idea, the discussion around training, and Eric, I know you know far more than I do about that, but there was discussion about specific training that they do with peer recovery support specialists. And I don't know if that framework is, in any kind of regulation. It was just what was presented to the other subcommittee. So I just wanted to give you that information.
Thank you for the background, Ms. Hale. I appreciate you sharing your knowledge from that subcommittee. I believe this recommendation here is trying to one, offer the opportunity to lift up the peer recovery support specialists, as Eric mentioned, so that it's equal to or exceeds an opportunity for reimbursement like the CHWs have. And additionally, I mean, if a PRSS is not available in a community that's looking for some type of a community peer navigator, but CHWs are available or are an opportunity to get a foot in the door to then build a peer community, particularly in rural and frontier communities. For me, there's still some utility in this particular recommendation, and happy to discuss that broadly. I don't know off the top of my head what all of the educational requirements are. I am a certified prevention specialist, so I'm more familiar with those particular certification requirements. And they're, aside from ethics, are very broad around multiple different areas for prevention and training. So I don't know if it'd be helpful to have an hour or so in harm reduction that would help support moving this forward and elevating this particular area.
Well, I don't know how much more in the weeds we want to get. My analysis of the training overlap is similar to, and I keep making this comparison, but MFTs and CPCs, marriage and family therapists, and clinical professional counselors. About 90% of our education, in my estimation, is pretty much the same. We're learning how to work with clients, learning about ethics, case management, treatment planning, things of that sort, diagnosing. It's really that last 10% that sort of then separates. And from my perspective, somebody could argue otherwise. I think peers and community health workers, essentially 80 or 90, but the majority of what's covered is very similar. How to work with with clients, case management, kinds of things, how you track those sorts of things, evidence-based practice, ethics, the community resources. And then that last 10, 20, 30%, whatever percentage you feel that is really what separates the two.
Yeah, thank you, Mr. Schoen. I appreciate that. I imagine there, if we had other, PRSS on here, I know we've attempted to get a presentation specific to the one that Ms. Hale is discussing, to help us understand this a little bit more, and folks weren't unfortunately unavailable within our timeline to be able to assist with this particular recommendation. I'm of the opinion to move this forward in its newly adapted form and have a discussion with the larger SURG committee, since this is for the harm reduction, but open to committee members' thoughts on that approach.
Let's do it.
I'll second that. Yep. Debbie Nadler.
Right. Wonderful. Ms. Rodriguez, do we need to vote on these, or just the updated recommendations are fine as is?
I would ask Rosalie, I see she just put her camera on.
So because you are updating the recommendations, a vote at some point, that could be at the end when you're done with all of them, or as you go. But since this is what you're going to be sending back to the larger SURG, a vote at some point.
Terrific. Wonderful. I believe this is the last one that we have worked to workshop. Is that correct? So with that very helpful and timely guidance, I would entertain a motion from subcommittee members to move the recommendations discussed today in their workshopped format to the larger SURG committee in December, with additional information forthcoming where indicated on a few of the recommendations.
So moved, Madam Chair.
Here,
Second, Debbie Nadler. Thank you.
thank you. So I have a motion from Vice Chair Schoen and a second from Ms. Nadler. All in favor say aye.
Aye.
Aye. Or any opposition? Or abstentions? Wonderful. So our work here today has encompassed many of these recommendations. Thank you all for your discussion and input, and to our subject matter experts for joining, specifically Mr. Meza, with ensuring that we could allocate number one appropriately. All right. With that, I'm going to move on to agenda item number 5. Which is for us to discuss a report out for the December SURG meeting. I'm curious, last time around, I know Vice Chair Schoen presented the 3, 4, 5, 6 prevention subcommittee recommendations, and then I took on the harm reduction recommendations. Open to how to approach this the next time around. Vice Chair Schoen, are you open to presenting the 2 SURG committee updated recommendations? I can take on the harm reduction ones.
Sure. Happy to split it however you'd like.
Wonderful. That was really helpful. I think then the larger SURG committee doesn't have to hear from me the entire time for these particular recommendations.
I do have to say a great big thank you to you for stepping in so quickly when I was having my technical difficulties. Thank you for that.
Of course, I know you would have done the same if I were in the same boat. So wonderful. So we have a plan for the December meeting and the language for the majority of these to move forward. With that, I'll move on to agenda item number 6, which is public comment. This is our second period of public comment. Ms. Rodriguez, are there any additional information that we need to read into the record for this second period of public comment?
I don't believe we need to read it a second time, so I'm just looking. I'll pause for a moment, but I'm not seeing anybody indicating that they wish to provide public comment.
Wonderful. If folks would like to provide public comment, you're welcome to raise your hand or indicate by doing so at this time.
Chair Johnson,
Yes.
this is Bryce Shields for the record.
Wonderful. Go ahead.
I may be in the wrong committee meeting. I was under the impression that we were going to discuss one of the recommendations regarding allocating funds for additional medical examiners, and specifically medical examiners who would be dedicated to investigating homicides related to overdose. Is that on the agenda?
Fall under the, because there was another subcommittee, a response subcommittee meeting that was
Right.
also at 11 o'clock.
Right, but this is, I received the Zoom meeting for this meeting.
There were two. It's possible you were sent the wrong one. I can put in the chat a link to the agenda. The other, I don't know if it's still going on. I think they started a little late due to quorum issues, though I'm not sure if they gained quorum or if they're rescheduling.
Okay.
The link I just sent is to the response subcommittee agenda. I'm guessing that's the one because it was set to occur at the same time.
And this is the prevention?
Yes.
Okay, I attended my first meeting 2 weeks ago, and so I'm still trying to get up to speed. It was still very interesting to listen to everybody's comments today, but I will log off and try to get on that subcommittee meeting.
Yeah.
And Mr. Shields, I do see you are on the response subcommittee calendar invite as well. So I think you probably just had both on.
Oh, okay. One other thing, an item that you guys discussed today that I wanted to comment on. I think it's interesting, the discussion regarding decriminalization of smoking devices for drug paraphernalia. I would just ask this subcommittee to consider the impact that will have on law enforcement, particularly as it relates to developing probable cause to search vehicles. Just from my standpoint as a prosecutor, when we have NHP troopers or sheriff's deputies or local PD approaching a vehicle, a lot of their investigations start with that probable cause when they see a smoking device, on a dashboard or in a cup holder or something like that. And I think if there's a BDR that eventually becomes law decriminalizing smoking devices, that's really going to have a significant impact on law enforcement's ability to investigate not only drug trafficking and drug sales on the highway and on our streets, but also driving under the influence crimes, because that's usually a strong indicator that somebody is operating under the influence of a controlled substance when they have a obvious drug smoking device located in their car.
Thank you for your public comment. I appreciate inputting that into the record.
All right. Thanks, everybody. Have a good day.
Thank you. Other folks who are interested in making a public comment at this time?
Chair Johnson, I do not. Oh, I do see Debbie Nadler has her hand raised now.
Wonderful.
Just want to thank everybody. Y'all are great. That's all. Thank you, Jessica. Thank you, Emma. Thank you, Eric. Thank you. Y'all are awesome. Thank you.
Wonderful. Thank you, Ms. Nadler. If there's no one else for public comment, I'm going to move to agenda item number 7, is our adjournment. So thank you all. I echo Ms. Nadler's comments and grateful for this committee and the work that we've been doing.
I as well. Take care, everybody.
Thank you. Thank you again
Thank
for the
you.
folks who joined to listen in, to the fellow committee members, and as always to the very well organized SEI team. Very grateful to you all. Thank you so much.
Thank you, Jessica. Bye.